Hello everyone and welcome to my channel. Today we are going to have a discussion on a very interesting topic, and that topic is known as vasomotor reversal of Del. Now students, this is a very interesting topic, so please be with us till the end of this video so that you understand this concept very clearly. In the beginning, to understand the vasomotor reversal of Del, we have to first know about two receptors, and those two receptors are the adrenergic receptors or the alpha or the beta receptors. Now these alpha receptors, they are divided into further two more subclasses, that is you have got alpha 1 and alpha 2. Similarly, the beta receptors, they are also divided into three more subclasses, that is beta 1, beta 2 and you have got the beta 3 receptors. Now if we come to the location of these receptors, alpha 1, it is mostly present in the blood vessels. Now alpha 2, this is a autoreceptor. Beta 1, it is located in the, primarily it is located in the heart. Beta 2, it is located in the bronchus as well as in the blood vessels. And beta 3, it is located in the adipose tissue. So now this is the distribution of the alpha and the beta receptors. So if you look into this point very clearly, you will see that in the blood vessels we have got two kinds of receptors. One is the alpha 1 receptor and the second one is a beta 2 receptor. Now if alpha 1 is stimulated, it will lead to vasoconstriction. And hence there will be increase in the blood pressure. Now if beta 2 is stimulated, it is going to cause vasodilatation or vasodilation, and this is ultimately going to cause decrease in the blood pressure. So students, just remember these 2 points, that if alpha 1 is stimulated, it will cause vasoconstriction, ultimately lead to increase in blood pressure. If beta 2 is stimulated, it is going to cause vasodilatation and ultimately there will be decrease in the blood pressure. Now in this vasomotor reversal of Del, to understand this phenomenon, first we have to know what is the action of adrenaline on the blood vessels. Now adrenaline, it acts on all the receptors, that is it acts on alpha 1 and it stimulates them, alpha 2, beta 1, beta 2 and beta 3, although the action on beta 3 is weak. So since adrenaline, if we now look at the blood vessel action, so adrenaline is going to stimulate both the alpha 1 as well as the beta 2 receptors. Now the receptors of alpha 1, they are strong receptors. Whereas the receptors of beta 2, they are sensitive receptors. That means that even if a small dose of adrenaline is there, it is going to stimulate the beta 2 receptors in a very small dose, since the beta 2 receptors are sensitive to adrenaline. And if there is a high dose of adrenaline within the blood, then in such a condition, since the alpha 1 is a much stronger receptor than the beta 2, hence the action of alpha 1, this is going to predominate. So the action of alpha 1 predominates in case of a high quantity of adrenaline in the blood. So now, suppose we give the patient adrenaline, right? So initially what is going to happen, that adrenaline, in a high dose adrenaline, if we give the patient a high dose adrenaline, then what is going to happen? That alpha 1 receptors will be stimulated first because they are strong receptors. Now, because of the stimulation of alpha 1 receptors, I have already told you, it is going to cause vasoconstriction. And because of this vasoconstriction, there will be increase in the BP. So suppose we plot the BP. So in the first condition, what is going to happen? In the first condition, when the action of adrenaline is on the alpha 1 receptors, because of vasoconstriction, the BP is going to increase. Now after some time, there will be metabolism of this adrenaline and there will be reuptake of adrenaline. So once metabolism and reuptake of adrenaline starts to occur, the concentration of adrenaline is going to come down. So as the concentration comes down, now the BP will also start to come down. But we all know that we have got another receptor, that is the beta 2, and this beta 2, it is a sensitive receptor. Hence, as long as even a low dose of adrenaline, small dose of adrenaline, will be able to stimulate this beta 2 receptor. So as long as the action of alpha was there, we saw first the increase in BP, and then as the action of alpha, or rather the concentration of adrenaline started coming down, the BP also started to return back to the baseline. But after some time, it is going to stimulate the beta 2. So once beta 2 is stimulated, then this beta 2, it is going to cause vasodilation. And because of vasodilation, there will be decrease in the blood pressure. So now the BP will keep on decreasing. After some time again, since the metabolism of adrenaline is going on, so now the adrenaline, once the action of adrenaline beta 2 also is finished, the vasodilation will be over and the BP will now come back to the original point or the normal point. So this curve of adrenaline that happens on the blood pressure, this is known as the biphasic response. So this is the biphasic response of adrenaline to on the BP. And this biphasic response occurs because initially there is stimulation of the alpha 1 receptors, which are strong receptors, followed by the stimulation of the beta 2 receptors. Now you also have another neurotransmitter, and that is noradrenaline. Now this noradrenaline, it acts on alpha 1, alpha 2, beta 1 and beta 3. But students, remember, noradrenaline has got no beta 2 action. So the beta 2 action of noradrenaline is not there. That means if we come to the blood vessels, then we know that it is going to stimulate alpha 1, which will cause vasoconstriction, which will lead to increase in the BP. But there is no beta 2 action of noradrenaline. So naturally, the vasodilation phase which occurs because of beta 2, that is not going to happen with noradrenaline. Now the action of adrenaline on heart is also very important, because adrenaline, what it does is that it actually stimulates the SA node, and we know that SA node is the impulse generator. So since adrenaline stimulates the SA node, hence it leads to impulse generation. It also stimulates the latent pacemakers on the AV node as well as on the Purkinje fibers. So the latent pacemakers on AV node and the Purkinje fibers, they are also activated. So now if there is a high dose of adrenaline within the system, it is going to activate the SA node as well as the latent pacemakers on AV node and Purkinje fibers. Because of this, adrenaline in high doses can cause arrhythmias. Hence, we don't give adrenaline in high doses IV to the patient because the chances of development of arrhythmias. So now with these points, let us now understand the vasomotor reversal of Del. Suppose we have given a patient, let us suppose we have given a patient, or rather before going to that, let us take an example and understand this phenomenon of adrenaline. So let us suppose that the patient has 500 molecules of adrenaline, suppose, within the system or within the blood. So you have got two kinds of receptors, the alpha 1, which is a strong receptor, and a beta 2, which is a sensitive receptor. So since there is a high amount of adrenaline, and let us suppose that in order to stimulate alpha 1, you need 100 molecules of adrenaline, and to stimulate beta 2, you need 10 molecules because it is sensitive, so less molecules of adrenaline is going to stimulate it. And how many molecules of adrenaline I have in the system? 500. So now this 500 molecules of adrenaline, it will act on alpha 1. Now once 500 molecules of adrenaline acts on alpha 1, naturally it will be stimulated, and since it is a strong receptor, the BP will keep on increasing because of vasoconstriction. But due to metabolism of this 500 molecules, since these 500 molecules of adrenaline will also be metabolized, so the quantity is going to come down upon metabolism. So as the quantity comes down, the effect is also going to come down. Now, as the quantity of adrenaline, it keeps on decreasing, after some time it is going to stimulate the beta receptors, as I've already told you, and hence you are going to see this biphasic response. There will be hypotension because of vasodilation, and once the action of adrenaline is completely finished, the BP will go back to the baseline, and this is the biphasic response as we have already discussed. Now suppose in this kind of a patient, or a patient who has got a high dose of adrenaline, suppose we give an alpha blocker first. Now let us see what is going to happen. Suppose we give an alpha blocker first, an alpha blocker such as phentolamine. Now once I give alpha blocker to the patient, adrenaline was first supposed to act on alpha 1 and there would be vasoconstriction, but since I have given alpha blocker to the patient, now this action of alpha 1, this will not be there. So now the only action that is possible, that will be beta 2. Again, due to beta 2, we know it would lead to vasodilation and ultimately decrease in BP. So if a patient, prior to giving adrenaline, if I give alpha blocker, now this phase of vasoconstriction will not be there. Rather, due to beta 2, there will be vasodilation. And as the action will be terminated, the BP will return to normal. So what was adrenaline supposed to do? It was supposed to increase the BP and then consequently decrease the BP. But after giving alpha blocker, what it is doing? It is directly decreasing the BP. And this is a vasomotor function. So now the vasomotor function of adrenaline upon giving an alpha blocker has been reversed. And this phenomenon is known as the vasomotor reversal. And it was discovered by a scientist, Dale, and hence the name vasomotor reversal of Dale. Now students, I have already told you that this is going to happen when there will be high dose of adrenaline within the system. But I have also told you before that high dose of adrenaline, it is going to cause arrhythmias. It is going to predispose the heart to the development of arrhythmias. So now, why do we need to study this mechanism then? Because in body, there is a condition that can cause increased amount of adrenaline in the system. And that condition is known as pheochromocytoma. Now pheochromocytoma, this is a tumor of the adrenal medulla. It can cause, or rather it can release both adrenaline as well as noradrenaline. So suppose you have got a patient who is or rather you have got a patient whose tumor is secreting adrenaline. Now 90% patients of pheochromocytoma, they will present with hypertension. And that pheochromocytoma, the patient, 90% of the patient, they are going to present with hypertension. And the patient that we are discussing, his pheochromocytoma is releasing adrenaline. Now you see the patient, you see that the patient is complaining of hypertension, and you think that this hypertension is because of vasoconstriction, which in turn is because of the stimulation of alpha 1. So the obvious choice will be to give an alpha blocker. And the moment you give alpha blocker to this patient, see what is going to happen. Since you have given alpha blocker to this patient, now the vasoconstriction phase will not be possible. The only receptor that is possible, the only receptor that is now that can be activated is beta 2. And because of beta 2, there will be vasodilation. Now, since it is an adrenaline producing tumor, there will be high amounts of adrenaline within the system. And let us just go back to the previous example where we had alpha 1 and beta 2 receptors, and let us suppose there are 500 molecules of adrenaline. Alpha 1 needs 100 molecules to be activated, let us suppose, and beta 2 needs 10. Now since you have given alpha blocker to this patient, this thing is not going to happen. Now the entire 500 molecules of adrenaline, this is going to act on the beta 2. The level of hypotension will be a much more because the entire adrenaline is now acting on the beta 2 receptors only. And since the amount is also very high, so due to very high amount and the entire receptors being stimulated, the time taken to go back to metabolism and go back to normal will be very high. Hence, the patient will have very dangerous hypotension. So students, remember, a pheochromocytoma patient which is an adrenaline secreting tumor, if you give alpha blocker, and suppose initially the patient had a systolic BP of 200, now after giving alpha blocker, suddenly it is going to come down to 20. And reviving of this patient will be very, very impossible. So this is where the clinical application of vasomotor reversal is there in cases of pheochromocytoma patients. So what to do in these kinds of patients? So now, what is the way to, suppose the BP is high, so what is the way to counteract this increased BP? The way to counteract this increased BP is you can give the patient an alpha as well as a beta blocker. Now, if you block the alpha as well as the beta, then the vasoconstriction as well as the dangerous hypotension that was about to occur, both of them will not be occurring, and the BP will normally return to the baseline. So for a pheochromocytoma patient who is secreting adrenaline and presenting with hypertension, the drug that we give to control hypertension is alpha plus beta blocker. Now, if the patient is secreting noradrenaline, or if the tumor is rather secreting noradrenaline, we know that noradrenaline acts on alpha 1, alpha 2 and on beta 1 and beta 3. There is no beta 2 action. So, if noradrenaline is there, there will be increase in the blood pressure due to our stimulation of alpha 1. Now, as the metabolism of noradrenaline is occurring, the BP is going to come down. And to the baseline. Now, since beta 2 is not stimulated, hence this hypotension component is not going to occur. So, if a patient of pheochromocytoma is secreting noradrenaline, in that case, we can give alpha blockers. Because naturally the beta 2 action is not there in a noradrenaline. So students, please remember, for pheochromocytoma, if it is an adrenaline secreting tumor, you can give alpha plus beta blocker to counteract the hypertension. If it is a noradrenaline secreting tumor, only in that case you can give alpha blocker alone. So that's it for today, guys. Hope you like this video, and if you do, then please give it a thumbs up. Also, let us know down in the comments below what other topic you would like us to discuss, and please subscribe to my channel and press the bell icon so that you don't miss out on any more upcoming videos. See you with another new topic. Until then, goodbye and take care.